Okay, welcome to your next seminar. This one is NMT Informed Assessment and Treatment Intervention. So NMT is short for the Neurosequential Model of Therapeutics, and that was developed by Dr. Perry, which we'll talk more about in just a minute. But the objectives today for this presentation are to develop a rudimentary understanding of what NMT is. So NMT, its basic training takes about 10 to 12 months to complete. So today is just going to be a very basic kind of bird's eye view of the model. You'll get a better understanding of the role of NMT in our psychological evaluations that we do here at Family Forward. Identify how trauma can masquerade as other diagnoses, and finally introduce factors leading to the utility of recommendations for families. So before we get into all of that, let me just tell you a little bit about Family Forward. Within Family Forward is a developmental trauma center, which is comprised of four major components, four different programs, and that includes parent education and training services. So we offer a lot of services for those who are training to become foster parents, those who are already foster parents or adoptive parents, or those just looking to learn more about developmental trauma and challenges with raising children and adolescents. We offer therapy services, both in-home and in-office services. Now we are also offering a virtual component and group therapy services. We have a therapeutic preschool, which serves children 3 to 5 years old who've been unsuccessful in a more typical preschool setting. And then finally, trauma assessments and psychological evaluations, which is what we will talk more about today. So the neurosequential model of therapeutics was developed by Dr. Bruce Perry through the Neurosequential Network. And part of that includes the neurosequential model of therapeutics, but there are also other different branches, including the neurosequential model for education, for sports, and a variety of different aspects. So here's the link here if you're interested in learning more about that. But really, it's a neuroscience-informed, developmentally sensitive approach to clinical problem solving. It itself is a framework and not a therapeutic approach. And so we use it to inform our conceptualization, better understand the client and their development, and then from there, best select treatment options that are most appropriate for where the child is in their development. This model takes into consideration both adverse experiences that the child has experienced, starting from as young as in utero, and also buffering relational experiences that the child has had. We'll talk more about that here as we go. So here clearly is a picture of the brain, right? I understand, not so much. It is a very simplified view of four major components of the brain, and we call it the upside down triangle because that's what it is. But essentially, this is a simplistic visual of the brain and how it's structured, with more rudimentary components down in the bottom part of the triangle and getting more complex as you move up throughout. So starting with the brain stem, this is the area of the brain that is responsible for basic body functioning. So things like cardiovascular health, temperature modulation, heart rate, blood pressure, things like that. This, to some, is referred to as the reptilian brain because it is a part of the brain that all living beings need in order to survive and keep functioning. As we move up, we get to the diencephalon, and this part of the brain focuses on self-regulation. So how can we as humans regulate ourselves through sleep, through eating, and through emotional regulation? So we see a lot of our clients that come in struggle with this area, struggle to find that sweet spot between over aroused, dysregulated, maybe acting out, maybe aggressive, and under aroused. Those clients that we see that are disconnected from their environment, maybe seem spacey or inattentive, just generally dissociative. So we see a lot of our clients who are struggling with this regulation component. As we continue going up to the limbic system, this part of the brain holds a lot of the relational capacity of each other. So relational intimacy in general can be really difficult for the population that we see. Kids who have had relational trauma in their past tend to struggle with intimacy, not even romantic intimacy, but just connecting on a deeper level with other humans. That can be it can be uncomfortable, it can be threatening, and honestly, it can be downright frightening for some, because that intimacy is a reflection of what they experience as babies or as toddlers, or even as elementary age, connecting with their caregivers who later then turned around and hurt them in one way or another. That is proven to them to be unsafe. So that area can be particularly difficult and scary. And so things that we see here are things like attachment, affect regulation, attunement with others, more subtle nonverbal cues, things like that, and reward. So what kinds of things are rewarding to that child? Is it relational connection, or is it other things like food or sex or self-harm behaviors? Then finally, we get to the cortex. This is the most complex part of the brain and allows for the most complex thinking. So things here might be academics, abstract thinking, concrete thought, executive functioning skills, and really just more advanced human capabilities. Things like morality, delayed gratification, all of those kinds of things live in this top part of the brain. So this image in general just gives us a very basic way of thinking about the brain, and then can inform us as we continue here. So as we get more into NMT and the brain map, which is part of the assessment that we provide, this brain map key highlights the specific aspects of this triangle that we just talked about. So down at the bottom, that pink area representing the brainstem. As we move up, the diencephalon, the limbic system, and the cortex, you can see how the colors change there. And each one of those little boxes represents another area that we are focusing on with the clients that come in to see us. So we are asking questions, we're kind of exploring these different areas with the kids to see how they're functioning now in each one of these areas. And that gives us a better understanding about how those early experiences has impact subtle and not so subtle aspects of their behavior and their brain functioning. What I think is really important to note here is that these little boxes, these little parts of the brain don't act independently. It's really easy to look at this chart and see how each one of these seems like its own identity, but in reality, they are all connected. And so let me give you an example. So sleep, you can see that in the yellow diencephalon section. That area, if I don't get a good night's sleep, my next day, I am not at my best. I am not as attuned with others. I'm not making the healthiest eating choices. My mood is not as regulated. I'm not thinking as clearly. So even that one component can be really integrated with a lot of other little boxes that you see on there. And that's just one example. But we can see how that might reflect that interconnection for our clients as well. So as we collect data for the brain map, we do look at that current functioning. So that's what we call individual CNS functioning, and you could see that there on the right side of the slide. On the left side, it will show you some of the other information that we collect. So we explore a child's history, we look at genetic and epigenetic factors, we look at adverse experiences and relational health buffers to their early experiences. And each one of these is broken down into different stages of development, because infancy, things are going to impact the child differently than when the child is 14 years old. And so each one of these aspects, adverse experiences, relational health, we are exploring during each different stage of that child's development. We'll ask questions about the timing, the severity, the predictability of these events, and what other kinds of supports may have been in place to help that child along. So all of that information goes into our metric. The metric helps provide a different lens for the families and for the therapeutic web for all the people that are involved in that child's life to understand that child a little bit differently. I've always said that if our families leave our office with a different, more strength-based way of looking at their child, we've been successful. All other things aside, if they're able to use a different lens to be able to understand their child's behavior and put it in context, awesome. It provides us a template to help decide where therapy should start. So as we go back to that brain image, if we're really struggling down, let's say in the diencephalon, the part where we talk about self-regulation, it's going to be really difficult to hone in on those cognitive skills until we've been able to master or at least improve some of the self-regulation skills. And that, for example, I see that a lot with kids who go in for treatment for TFCBT, for example, trauma-focused cognitive behavioral therapy. They might really succeed in the therapy session with those complex thinking skills. So things like coping skill development, thinking about what errors in their process and thinking and actions and behaviors that they might have. But then once they get out of the therapy session and something happens, they feel challenged, they feel frustrated, they get angry. For some reason those skills go out the window. And I can't tell you how many clients that I've had who say, yeah, I know it, I'm ready to use these skills. And then once something happens in their regular life, they're not able to access them. And that's because once they get dysregulated, they're not able to kind of climb up that brain ladder and get to that point to use those other skills, which we'll talk about more in a minute. But that helps us to decide where therapy should start. So in that instance, we should back up probably and start working more on those self-regulation skills before we get to those more advanced concepts. And it also provides hope and understanding to families. It allows the space for families to understand that it's not personal. It's not about necessarily particular caregiving or individual choices that we've made, but more so understanding the child's behavior through the context of their experience. So here it is. Here is the metric report. This is just an example of what we might provide for a family. So on the right side, you'll see those same boxes that I showed you a few minutes ago, where we talked about sleep and affect regulation and those different things. The bottom box that has more green, that is age typical. So for every age, we're going to expect that their brain is a different stage of development. For example, the frontal cortex is not expected to be fully developed until your 20s. So we would not expect a 6-year-old, for example, to be fully developed. And then, so we offer an age-typical sample to know really what we're comparing to in terms of what should be expected for that child's development for that age. The green boxes represent areas of brain functioning that are well developed. The yellow areas represent areas of the brain that are in development. They may be episodic. Sometimes the child's able to use those skills well, sometimes not so well. Whereas the pink and red areas are really underdeveloped areas that need some pretty strong attention and focus. So right off the bat, you can see in this example, the child here is struggling in a lot of areas. You can see that dark red, of course, your eye goes to that to see one area in which the child is having difficulty. But you can also see a little green box there at the top. And so I just want to also point out that while as much as we focus on the areas that need work, we're also looking for the areas that the child is functioning well, and how do we pull off those strengths to help the child function. So we are using a lot of different sources to gather this information. We're doing clinical interviews with really anybody that wants to participate. So anybody in that therapeutic web. It might be caregivers, caseworkers, teachers, mentors, other family members. Anybody who's willing to participate and get this information can contribute on the front end as well. So So we're using clinical interviews, we're using observations of the child and the family in the session. We're providing different measures in the session, so we're collecting actual test data as well. And then we are meeting with the client themselves and working with them in a variety of different environments. So on the left side of this picture here, you could see the green line and the red line. And the green line represents relational buffers. So what kind of experiences has a child had in their life that has been supportive? And then on the red line, what kind of experiences have been adverse experiences for that child? And you can see where those lines cross over, and that's usually around the time where the child has been placed in an environment in which they do get more support and are better able to function. And underneath there, you see a little graph that kind of visually shows developmental risk. So it's kind of corresponding to the chart above as well. Okay. So the top chart on this page looks at the cortical modulation ratio, and that we refer to as a CMR, is really just a fancy way of saying how well can this child use those more advanced parts of their brain, so thinking, planning, executive functioning skills, abstract thought, in order to regulate those lower parts of the brain. So when anybody, a child, an adult, anybody, is overwhelmed, is overly stressed, is frightened, feels threatened or triggered, the instinct is for the brain to go into survival mode, fight, flight, freeze, whatever you want to refer it to, and go into protective mode, in which the first instinct is to fight somebody or to run away or to do whatever you need to do to stay safe. But most of us have developed our brains enough to be able to slow down and think about the situation long enough to know whether or not I really need to respond in those panic modes. So the classic example is you hear a loud boom outside, and for some people they pause and they say, was that a gunshot? Was that a car backfiring? Was that fireworks? But somebody who is struggling in regards to their CMR, in which the bottom parts of their brain react first and don't have enough time or space for the upper parts of their brain to kind of say, whoa, slow down, let's figure this out. They might crawl under the table. They might run out. They might get up and get ready to, see what's going on. So the CMR reflects those kinds of responses. How well is the client at hand able to slow down long enough to be able to think and respond using these thoughtful responses versus the more automatic primal responses? And these things are in some ways very functional. So for a child who has experienced trauma, their behaviors in one context has protected them, has kept them safe, has allowed them to predict when something bad is going to happen. It's when they get into the safe environment and are continuing to use those behaviors because that's what they've always used and that's what their brain is good at, that the behaviors become a little bit less functional and something that we might want to help them through. So let's use an example for some of the clients that we see. Let's say a child is, walking over for dinner and they drop their dinner plate on the floor, breaks the plate, the food goes everywhere, and they look up and they see their caregiver just looking exhausted. I mean, if you're a caregiver like me, by dinner time, something like that happens, it's like, okay, let's figure this out. But the child in that moment has two directions. One direction is, okay, I'm so embarrassed. I can't believe I did that. Or maybe we can sit down and talk about it. Maybe I can help you clean it up. Maybe I even cry a little bit. Maybe I go use some coping skills. We re-regulate, we regroup, manage the situation and kind of move on. The other direction, which is what we see for a lot of our clients, is the automatic response before anything even happens of that look in their caregiver's eyes. They are keen on being able to pick up nonverbal cues. They see that exhaustion, and to them that might mean, I'm in trouble now, look what I did. That might mean, oh no, she's angry, what's going to happen next? That might mean, she thinks I'm bad. I broke that plate and now I'm the worst kid and nobody's going to love me and I thought things were going well. So whatever that response is, they move into protective mode. That might mean running out of the house. That might mean shouting at somebody. That might mean picking up some of those pieces and saying, get away from me. Whatever that response is, with a child who has a lower CMR score, they're going to have more trouble slowing down long enough to say, it's the end of the day. Caregiver's tired. I just kind of made a mess. Let's all clean this up and figure this out, but instead react with that more urgent sense of protection. And then finally, this bottom chart here refers to functional domains. So everything that we've been talking about already, just in different language. So you could see the 4 different bars on the chart there. The first one being sensory regulation. So how well is a child able to integrate the sensory input that's coming in? The second one is a self-regulation. The third one is relational, and the fourth is cognitive. So on that chart there, you can see where the child is functioning better or having more trouble, where other children are in terms of typical age development, and then where a high-functioning adult would be. So there you could see on the lower parts of that chart might be areas that we might want to attend to before we get to those more advanced parts that we've been talking about. So state dependence of sense of time. This is another chart to say a lot of the same things that we've been talking about already. If we continue down the same line regarding children with lower CMRs, they tend to have more difficulty with regulation, like we've been talking about, in response to triggers. And this chart here highlights how that impacts the way that we're able to think, the way that we are able to understand time, the different parts of our brain that we're able to access. And even though we're talking about children today, this is applicable for everybody. This is absolutely applicable for me too. When I get stressed out, I'm just like everybody else. I'm moving up this chart. The difference is a child who has experienced developmental trauma and tends to be more on guard to start is more likely to move up this chart quicker, and we might not notice some of that progress as clearly. So most of us wake up in a calm state. We wake up kind of thinking about our day, planning, thinking about what's to come. We're able to be thoughtful about our day, think abstractly, thinking even, okay, so today's this meeting, I've got this presentation, and then tomorrow my son has picture day, so I'm going to have to start thinking about what he should wear. It's really advanced, and it's really comprehensive. And then, something happens, maybe I get to my first meeting late because it's raining outside and it's traffic, and honestly this place is like 30 minutes away from my house. I might show up to this my first meeting in an alert state, and that means I'm still present, I'm still engaged, I'm still active, but my thinking gets a little bit more concrete. I'm thinking more about what else is to come today than I am thinking about the rest of the week or the future. For most of our children, however, they're starting the day higher up on this chart already. They tend to be poor sleepers. They tend to be chronically dysregulated, whether that's hypervigilant, whether that's, the opposite of disconnected, or whether that's a little bit of a mix of both. Regardless, starting the day and maybe in a more alert phase. So I just want to recognize that's not them starting necessarily at their best, and we might need to come in with an intervention of some type right off the bat when they wake up to slow them down and to bring them into a calm state. Regardless, as things happen throughout the day, those can be major things, and those can be little things that build up. They might start to crawl up this chart a little bit. So let me give you an example. If a child wakes up in an alert state and gets to school, and they're sitting down for math, and math is not their favorite because math is hard, they're getting a little bit stressed out, and then the teacher says, we're going to have a pop quiz today. Oh my goodness, I already wasn't as good at this. Last night was a rough night. I didn't study. So now they're crawling up to the alarm state, and they're responding in a more emotional way. How am I going to get through this test? We're thinking much more about right now in hours and minutes. And we're getting kind of stressed out. And then, okay, well, let me go sharpen my pencil, and I get up, and somebody has their bag out, and they trip over the bag a little bit as they go to sharpen their pencil. Well, now I'm just stressed out. Now it just feels like too much, and okay, I'm just going to go sit down. I'm kind of getting a little bit more reactive. I'm thinking, how am I going to get through this test? Sit down, get ready to take the test, and the teacher calls me out on, not wearing the right clothing, or maybe I wasn't supposed to have my phone on the desk and I should have had it in the bag, or something like that. And then it seems like the child blows up. And to the teacher or to a caregiver, this kid just blew up out of nowhere, like nothing was happening. I just said, put your phone away, and they just exploded. But what we can see is those little factors are increasing this child's stress level and moving them up this ladder until their behavior becomes more reactive and reflexive, protective, really. And they're not able to access those more complex parts of the brain. So in that moment, they might respond in a way that's less socially appropriate because they're not in that calm state anymore. But also, let's think about their academics in that moment. Even if the teacher hadn't called them out, they're still thinking about, how am I going to get through this math test? And they don't have the access in the same way to those more complex parts of the brain, and they're not able to perform as well because now they're under, a great amount of stress, and that's just within the context of that math class. That's not considering what's going on at home. That's not considering what's going on socially. That's not considering if they've had a good breakfast or a good night's sleep. So we can really see how as our state changes, so does our functioning. Okay. All right, trauma within an NMT framework. So a lot of the things we've been talking about today, I'm sure that you've seen in your clients, in your practice. Some of the common symptoms that we see in developmental trauma are the same that everybody sees in their offices. So things like trouble staying in your seat or trouble concentrating, poor social skills, poor academics, aggressive behavior, maybe even sexualized behavior, isolation, withdrawal, awkwardness. Those are things that we all see coming through our door. Those are also things that we might diagnose as something else, such as ADHD or ODD or even autism spectrum disorder. And so we need to be really careful to be thoughtful about what is the context in which these behaviors are brought in. We see a lot of diagnoses, for example, of ADHD after meeting with the psychiatrist for 15 minutes because they get a limited context of what those symptoms are. They hear, I'm out of my seat all the time, I have a hard time concentrating, I lose things, I'm disorganized. Seems like ADHD to me, let's see if some medication will work. That makes a lot of sense. But when we back up and we think about that example of the child in the math class just now, we can see they might be fidgety. They might be thinking about, what happens if I don't do well on this math test? Am I going to get hurt at home because of that? They might think, I didn't get breakfast this morning and I'm so hungry and I hope I get dinner tonight. They might be thinking about, I don't know if I'm going to get kicked out of this foster home today or next week. Or this is my 6th school in 6 years, so I'm just feeling generally uncomfortable. All those different components that we think about can contribute to symptoms that look like ADHD, but are rooted entirely in something different. So, there's a litany of reasons why somebody might show up with specific behaviors, and it's really up to us to investigate where are these behaviors coming from, why is the child presenting this way, to really truly understand. Because ultimately, if we try to address that child in terms of ADHD treatment interventions, we're going to be off the mark. We're going to be working on organizational skills when really it's rooted in safety and predictability of their environment and feeling secure enough to interact and trust other people. And we're not going to get there with organizational skills. So it's up to us to really explore how are these symptoms presenting and what are the possible reasons for those things. Okay. At Family Forward, we offer 2 different kinds of assessments. The first one is a trauma assessment, what we've referred to as a trauma assessment. And the main focus of that is our NMT brain metric. We do a number of different things to collect the information for that metric. We will do observations of the child in our offices. If the weather's nice, maybe we would go outside. We have a sensory room that can allow a child to move around, move their bodies, engage with different sensory items. Clinical interviews, again, like I said, with whoever is willing and engaged with the family and wants to participate. We provide measures, self-report measures. We will also engage the family in things like family intervention. So we might do an activity with the family so that we can see the dynamics and how the family works together. So we collect all these information, all these points of data, and write a report. And in that report, we include the background information of the client. Again, that context is so important. We include the observations that we had in the sessions. So what happened? How did the child respond to a low stimulation environment? How did they respond to a high stimulation environment? How did they respond when being separated from their caregiver, or if they were told no, or if they were challenged? All of those give us information. We'll include test data, and then recommendations on what to do with all of that information. And included in that is the brain metric. So we spend a lot of time going over education about child development, about trauma exposure, about a variety of different interventions that we might feel to be fitting for that child in terms of where they are in their development. And then we provide a few different opportunities for feedback, because that is an overwhelming amount of information that we are providing to families in regards to what recommendations we have and just general education. So we try to meet with families at least twice to be able to provide opportunities for that information to incubate, provide opportunities for families to come up with questions and think about these things and how do they apply to my specific family. And then we will also meet with the child as appropriate. And, if it's a younger child, maybe instead of giving them feedback that we collected in the report, maybe we'll write them a fable or tell them a story for them to better understand some of the information that we're providing. The entire testing session is adapted to try to meet the child where they are. So generally sessions are about 2 hours long, so as to not overwhelm anybody. And again, we are paying as close attention as we can to the individual needs of that client. If they're getting dysregulated, we're going to stop what we're doing and we're going to intervene and help them re-regulate. Again, this provides us more information. After all those things, about 3 months later, we'll follow up with a feedback in which the clinician themselves will call the family and just check in. How are things going? What other questions do you have now that you've had this information for a little while? How are the recommendations going? What are the barriers to implementing recommendations if we haven't been able to already? Are there other parties that are invested in this child that we can offer feedback to? So really providing multiple opportunities to engage with this information, engage with the families, so they genuinely feel heard, they genuinely feel that they have an action plan leaving our offices, and we're not just saying, okay, goodbye, good luck, but we're following up as well and making sure that that family is taken care of. The other type of evaluation that we offer is a typical psychological evaluation. So we do what you would normally expect for a psych eval, things like IQ, academics, personality functioning, social emotional functioning, diagnostics. Those are all things that we offer based on what the referral question is. So we're not going to do all of those things for all of our families. We're going to do what we feel like is most appropriate based on what the family is bringing in. While also keeping in mind that we don't want to over-test anybody. We don't want to give them measures just to give them measures. We're really going to try to cater to what the family needs. And that psych eval also includes the brain metrics. So regardless, they're all full of education about trauma and child development, recommendations, breaking down the sessions, having multiple feedback sessions, that's all included. What's most important that you see within our service provision, but also in regards to providing interventions for the child, is what we call dosing interventions. And that means we're not trying to give, for example, a bunch of information all at once, but we're trying to provide opportunities for providing information multiple times in smaller pieces to make it more manageable. So that means in terms of education about trauma, for example, we might start that at the very beginning interview with the family when it's appropriate, when it comes up. We're going to start on that dosing. And that's the same thing that we recommend in terms of interventions for our clients. We recommend having doses of interventions and not relying entirely on a 50-minute therapeutic session with a therapist once a week. That is amazing and totally helpful, but not ineffective so much as inefficient in terms of ongoing treatment for the child. Ideally, we are engaging family members, teachers, anybody that will participate in providing doses of intervention every day of the week, as regular as we can. And so that is going to look like small moments, so even just 5 minutes with the child of engaging in a way that's therapeutic. So it's not a therapeutic intervention, it's a therapeutic engagement. So for example, if the child struggles with self-regulation and let's say they wake up in that alarm state, we might sit down and read a book with them before we start our routine. That routine can be overwhelming, it can be noisy, it can be busy. How are we going to set the child up for success? We might try to bring them down right when they wake up. Maybe we'll rock in the chair for just a few minutes. That is an awesome way to be able to help with that regulation, to help bring them into a calm state. Also help for a really positive relational experience that is not so overwhelming that it becomes frightening. So again, it's much more effective if we're having moments of connection throughout the day rather than, let's say, a full day at Six Flags. You know, I think sometimes caregivers hear that we want to provide some relational intimacy and they're like, great, we'll plan out a day, we're going to go get our nails done, we're going to do this and that. And those things are wonderful. But when we talk about long-term change, we're looking for just the moments of connection. We're looking for after the school, when they get off the school bus, that the caregiver picks them up and genuinely is interested in what happened during their day. Maybe we sit down and have snack together just for a few minutes and talk about our days, what was easy, what was hard, things like that. And those are the kinds of doses that we're looking for. Let's see. Treatment intervention recommendations are based on where the child's needs are and may incorporate other professionals. So some of the things that we might recommend, for example, are occupational therapy services. Without a doubt, across the board, a lot of our kids come in with difficulties in sensory input. Environments may be entirely overstimulating. The classroom and school itself might be overstimulating. Some children are seeking stimulation. Those are the kids who might be touching everything or running into things when they walk down the hall or falling down when there's nothing in front of them to have fallen over. So we try to explore how sensory input makes a difference in how they interact with the world, and then we'll refer to occupational therapy as one example. So another way of talking about a therapeutic dose, it's a 3-minute interaction that can provide sufficient dosing of a therapeutic experience. Knowing that within that 3 minutes, it might just be 5 seconds of actual connection that that child is able to experience. But again, it's non-judgmental, it's being present with the child, it's listening, it's caring, and it's being genuine. And those experiences we're trying to provide within that child's window of tolerance. So if relational experiences, for example, are really intense and overwhelming for that child, we might need to make that even a little bit smaller. So as we can provide them an experience that is positive and not too much. A day at Six Flags might just be too much. It might be overstimulating. It might be too hot. I might get hungry. There's just all these people running around. That's a lot of you and me time where you're going to ask me questions when we stand in line. Whereas if we come home after school and sit down and have a snack, I can look at my snack for a while. I don't even have to necessarily look at you. We can eat when things get a little quiet. And then I can get up and I can go do something else. But it provides just like a dose of medicine, a little bit at a time. Okay, trauma-informed assessments. So like I said, we really try to be trauma-informed regarding our assessments from the very beginning. So we will try to pace, we'll try to dose information as we can, and we'll try to dose our sessions as well. We provide ongoing communication, and we try to be mindful of where the state that the child is in when they're in our session too. Sometimes kids hear, I'm going to go see a doctor, and they get scared. And they think, I'm going to get a shot. I don't know what's going to happen. Last time I had to put this paper dress on, and I don't like that. But we are trying to be attuned to that and recognize when they come in and have them put their best self forward when they actually get to the testing part of the session. So we'll spend a lot of time connecting with them, or going to the sensory room, or giving them an exercise ball to sit on instead of a regular chair, or letting them hold a weighted mat. So we'll try to problem solve and explore those different things while we have the opportunity to do so, which then provides more information on the other end of our sessions to be able to provide recommendations that are really useful and applicable for this family. The other model that we use when it comes to our assessments is the collaborative assessment model. So this model really focuses on removing the sterile parts of assessments and making them more therapeutic. We try to be transparent with the families from the very beginning. Why am I choosing these activities? Why am I choosing these measures? Why are we doing things the way that we're doing? And what can I expect throughout this whole process? We want to try to take the mystery out of this whole thing and engage the families in being participants in the evaluations rather than just observers or, patients. So part of that might be we collect a measure and we see some scales are elevated that surprise us, and we might stop and call the caregiver and say, hey, let's just talk about this. What are you thinking about it? Do you feel like this fits? What do you notice? Let's learn more about it. And that might change the course of the rest of the evaluation. But we want caregivers to be able to have a voice, and we want clients to be able to have a voice. We might also do interventions, family interventions in session. So that could be something really structured, like a family therapy-esque activity, or that might be, just like a fun game in which they play together and we kind of see just how they go back and forth with one another. And so we offer opportunities for therapeutic moments. We want to be mindful that this is a stressful experience and that the family has been under a lot of stress, and to create the space and the security and the safety for them to be vulnerable if that's where they're at, or if that's what would be helpful for the assessment, and not just an in and out kind of experience. We find too that as families are able to be more vulnerable and really connect with the clinicians, that they're more intensely engaged with the feedback and the information that we provide. They're more open, and they are more willing to engage in kind of this back and forth of maybe I get stressed out when my kid does that and I don't know how to respond. Those vulnerable moments that really allow us to say, yeah, that makes a lot of sense. Let's figure this out together. Because essentially, families and caregivers are the most important when it comes to this process in caring for our kids and caring for the results that we have and applying them to our families. We really do a lot of work with the caregivers to frame our recommendations in a way that they can hear them, and also in a way that is applicable for the caregivers as well as the clients themselves. We talk a lot about where the child is developmentally rather than just focusing on their chronological age, because children don't, unfortunately, develop in a really super linear way. Instead, they might be functioning academically as a 14-year-old. They might be functioning socially as a 10-year-old, and they might be functioning emotionally more like a 6-year-old. And that's when we have the parents come in who say something like, yeah, they do fine at school and they come home and it's just like they're 5 years old. Like, I don't understand. I said no to a candy bar as a snack and they just lost it like a toddler. And we might really validate that and say, yeah. So if we're thinking about the child behaving much younger in that moment, it's because they are much younger in that moment. Their brain functioning is much younger in that moment. And we need to respond to them much younger in that moment. And for some, that might be kind of uncomfortable at first. We might have a 10-year-old who's melting down, who instead of saying, go to your room or let's do a timeout, we might say, come here and sit on my lap and let's regulate together. Let's co-regulate. Because a lot of these kids need help through that process. And it's only when we back up and we recognize what they've missed in those early years, are we really able to provide that co-regulation for them. So in other words, helping use our regulatory state to be able to help regulate them. Because the reality is an unregulated caregiver can't regulate an unregulated child. And that's another reason that we put a lot of attention on the caregivers, is because if the caregivers can't regulate themselves when in these stressful moments, we need to problem solve that, because they are not going to be able to come in and regulate a child. And that's true for every parent. I mean, I can't tell you how many times I've been at the dinner table where my kids are screaming and they are asking for so many things all at once. And I have to check myself because I'm getting dysregulated and I can't expect them to regroup until I can regroup. So some of that is problem solving. What other supports do they have? What other kind of resources are available? Some of that is what skills do the caregivers need? And some of that is reconceptualizing, for example, what dinner time looks like so that we can be successful through that. So it's re-understanding what the problem is and what the solution is. Each person has a unique pathway to the present and deserves individualized care. So like I said, we are paying a lot of attention to that particular family and adapting as we go to make things really useful for that family within their family culture. We are not using a one-size-fits-all from the very beginning, from what tests we choose, to how the session looks like, to what recommendations that we provide. The stress level of the caregivers is primary for us in order to focus long enough to be able to, like I said, regulate ourselves long enough to regulate our children. And I say our because, like I said, that's true for me as a parent, that's true for all parents. Finding ways to help with the co-regulation. And we are also looking for ways to be able to minimize the stress of the recommendations that we're providing. So the reality is, even though we are here to help, they're coming into a clinician's office in which we are saying, here's my report, here are all these recommendations I think you should do, these are the ways I think you should change how your family system is run at home. And my goodness, if they're not overwhelmed enough, that is surely going to do it. So we try to do a lot of problem solving and a lot of exploration into the family's culture. What are they doing already? What kind of traditions and rituals do they have? What kind of systems do they have in place? What are their strengths? How do they do things well? And, so let me give you an example. I had a client who their family did bedtime just really well. It just really worked for this client. She was like 7 years old. And they would rock her and they would read books, they would turn the lights down, they would have some music on. It was so soothing for her, but it was contained to that one bedtime. So one of the things that we really try to focus on is how do we repurpose some of the strengths that the family already has, some of the things that they're doing well, maybe retime them, maybe place them differently throughout the day. So in this example, how do we take this bedtime routine and what works so well for this family and repurpose it at morning routine when things are chaotic and stressful? Maybe we can start the day rocking for a few minutes. Maybe we can bring her favorite book when we have to stand in line at the DMV for 30 minutes and we know it's not going to be easy. Maybe we can have some music on the way to school when they're getting nervous about what's to come. Maybe we can turn the lights down low during homework or put that music on. So how can we repurpose the resources that they already have None of that would cost a thing because they're already doing all of those things. They're already good at, they already are familiar with it, they're already comfortable, they already know how to use those things. We're just giving them information about why those things are useful and how can we be intentional about how we use them. So as much as possible, we try to repurpose what they're already doing to lower the amount of stress that we're putting on the families. Because ultimately, if we come in and we say, yeah, your bedtime's doing okay, but what if you did it like this instead? It's just going to be so overwhelming and everybody's going to be stressed out. So if we can if we can dose some of these changes, if we can dose some of the recommendations, we can dose some of these interventions, it all becomes a lot more tolerable. And we are calling, like I said, 3 months later to say, how's that going? Are we ready for the next dose? Can we see how things are progressing? So they are not alone in this process. The other major component in terms of recommendations is recognizing that interventions can be helpful for the family as a whole. So some of these things are going to be beneficial for everybody. Like I said, everybody moves through those different states. Everybody has stressors and needs times, opportunities to regulate. So how can we use that for everybody? So for example, my example of dinner time being difficult, we have built in a transition time between getting home and dinner time in which we have some quiet space if that's what we need, or we do an activity together because it was stressful for everybody and everybody needed that regulation time. So not just necessarily focusing on the client as the identified patient, but even in the classroom. Maybe the whole classroom can benefit from stretches in between subjects and things like that. It doesn't have to be unique to just that child. So that is a quick summary of NMT and our assessments and how these things work together. My name is Jamie Scaccia. I should have said that at the beginning, but here we are. I'm the manager of the assessment services at Family Forward within the Developmental Trauma Center. We also have an intake coordinator, Sarah Gamblin, and here's our contact information. Feel free to reach out if you want to learn more about the model that we use or the types of assessments that we do, or to see if your clients are a good fit, or if you just want to learn a little bit more. Thank you so much. Have a great day.